So what is lung fibrosis? Well, I talk to the patients talking about scarring of the lung, because that, in essence, is what it is. And the result of that to the lung is that the lungs become stiff and they shrink in size. So our patients typically have lung volumes that are half the size of what they should be. And I use the analogy that the lungs are a little like bellows. We're forever breathing in and out, and these bellows are essentially halving in size and are becoming stiff and require oiling. But to date, we have no great therapies for this condition. So we use the medical term interstitial lung disease to talk about all fibrotic lung conditions and make the point that there are over 200 types of lung fibrotic conditions. And I make the point that in the same way there are multiple ways of breaking your leg, there are multiple ways that the lungs can end up being scarred. And the relevance of this kind of categorization is that the therapies are slightly different depending on what is the cause for the fibrosis. And the importance of this, again, is coming to identifying the patients who are going to require a particular form of antifibrotic versus maybe other immunomodulatory therapies. What we're going to be talking about today is idiopathic pulmonary fibrosis, and this is the most common of all of those 200 subtypes, and it represents over 50% of all patients who have a form of lung fibrosis. Many of you will be aware of asbestos. Asbestos is a toxin to the lung and also causes lung fibrosis, but in fact, with occupational health and safety, we see very few cases of these today. But the commonest presentation we see is with this condition called IPF. Idiopathic meaning we don't know what caused it. Pulmonary, lung, fibrosis, scarring of the lung. So scarring of the lung that occurs typically in an older age group. So the mean age of presentation is 66 years, slight male predominance, and interestingly, there is a smoking history in the majority of patients who present with this. But this isn't the classical smoking-related lung disease, which of course is what is emphysema, which in many ways is the opposite, where the lungs actually become bigger and full of holes as this condition progresses. The IPF registry is giving us some demographic details about the epidemiology of this condition, and we think there's probably something around 10,000 cases in Australia, 100,000 in the US, increased numbers in the US. So smallish numbers in the total burden of lung disease, but still a significant number of patients with it.
It's idiopathic, but what's the best guess as to the smoking connection?
So the best guess is, and I'll come to this later, is that you have an injury to the lung. And in the same way as you fall over and get a scab or a graze on your knee, you get a scab, and then 2 months later it's gone back completely to normal. So one of the theories here, and if you talk to the patients, it's amazing how many of them have had dust exposure, whether it's from cigarette smoke, from working in the building industry. We think that eventually the repair mechanism becomes dysfunctional, that you injure the lung so many times, and that the 100th time you injure the lung, it no longer heals in a normal way, it heals in a dysfunctional way. And it's, again, going to the analogy of the grazed knee, you get a scab, but in fact, instead of the scab disappearing, the scab doubles in size, triples in size, and it also becomes self-perpetuating. So that's our best guess, but it remains idiopathic. We don't truly know, but there is certainly this sense of multiple injuries over multiple years, but eventually the lung can no longer heal in a normal way. So how do we work out whether or not the patient's got IPF as opposed to the other 299 causes of lung fibrosis? Well, we do it in what's called an MDT, or a multidisciplinary team meeting. And again, the relevance of this is that you need to identify the right disease before you can add in the right therapeutic. So what is an MDT? Well, this, as I said, is the gold standard for the diagnosis of this condition. And it basically is a meeting that we host every 2 weeks, where all new cases are presented to a team in a room similar to this, where we look at the history of exposures that they may have had. Have they been exposed to asbestos? We look at the CT scan, and we recognize that this condition has a particular appearance on the CT scan. And if required, we take a biopsy from the patient to confirm, again, there are characteristic features of it. And having a new patient gone through that process, they are then labeled with IPF if all the features meet up. So, talking about therapy for this condition, and
just that methodology,
mm-hmm.
is that for Australia or is that in the US as well?
No, so that is the global gold standard enriched in position papers, but the gold standard for diagnosis, you don't need a surgical biopsy, you don't need a CT scan per se, you need a group of experts sitting in a room that comprises of a clinician, a radiologist, and coming up with a consensus, and in essence it's a voting, is this IPF? And as is true in medicine, not always do patients' conditions fit into neat boxes, but this is how it is diagnosed globally. So the historical view of treating IPF was that it was felt to be an inflammatory condition, that the lungs become inflamed, you then get dysfunctional, you get pro-inflammatory cascades, and therefore you need to dampen the whole thing down. So the treatment approaches over the last 20 years have been focusing on that paradigm, that you need to use anti-inflammatory agents, corticosteroids, you need to switch off this exuberant immune system, so you use immunosuppressants, and these are just some of the drugs that have been used over the last 20 years. But when the global experts sat down 6 years ago and looked at all of the therapeutic agents that have been suggested, you can see that nobody was suggesting that any of them are efficacious in this condition. So not a single agent is in the 4 column, and in fact many of the treatments that have been routinely used for the last 10 to 20 years are actually, we're now strongly advising that patients do less well if they're given steroids, if they're given cyclosporin, if they're given combinational therapy. And you'll note at the moment, at the bottom is this drug called pirfenidone, which in 2011 there was some developing data suggesting that it had some efficacy, but there wasn't enough at that point for the experts to say that this should be part of routine therapy.
That would have flipped by now, presumably.
But that all changed in 2014, which was a big year for lung fibrosis, which was a game changer in a sense. For the first time, we had 2 manuscripts published in the leading scientific journal, the New England Journal of Medicine, suggesting that for the first time we had 2 agents that actually did change the natural history of this condition. So patients, instead of getting worse on the agent of interest, were actually improving on it. And the key graph is probably this one here. As I said, is that as this condition progresses, the lungs shrink in size. And what we're measuring here is forced vital capacity, which is in essence the size of the lungs. And you can see that those patients on placebo, the size of the lungs is deteriorating rapidly. But those on pirfenidone were on a preferred trajectory. But I make the point that these are not wonder drugs, that this condition is still progressing, the lungs are still shrinking, you're not curing the condition, you're not even holding the condition. You are still deteriorating, albeit at a less dramatic rate.
Was there a clear correlation between improved lung function and improved mortality?
So only when you pooled the data did you get a significant effect on mortality. You did get a mortality benefit with pirfenidone, with the second drug I'm going to talk about. And again, the primary endpoint in most of these studies is looking at the change of the volume of the lungs. And again, there are position papers out there establishing what should be the primary endpoints when it comes to doing interventional drug trials. And the main one is changing the size of it. And the secondary endpoints are things like mortality, quality of life, exercise capacity. But it came at a cost. Significant side effects of nausea, gastrointestinal upset, and of relevance to Australia, this drug is photosensitizing, so it makes you incredibly prone to sunburn and skin cancers if you don't cover up. In the same publication, a separate study looking at nintedanib, a different action, works on affecting fibroblasts, which are felt to be the abnormal cell that drives fibrosis in the lung. And this is an intracellular inhibitor of multiple tyrosine kinases. And again, this is, they did 2 parallel phase 3 studies called Impulses 1 and Impulse 2, and exactly identical results. And here are the 2 lines. Here's on placebo, and here's on active drug. But again, same point, these patients are still deteriorating, albeit at a less rate, and the secondary endpoints weren't met in this. So on the basis of this, both of these drugs were approved by the FDA. They were approved in Europe and Canada about a year ahead of that. And Australia is dragging its feet. I think it's reflecting on the data that suggests that these aren't wonder drugs. They are coming at a financial cost, and also a side effect profile. And particularly an issue with this drug is that 2/3 of patients will get rid of diarrhea. So you may buy a few months of life, but at the cost of miserable quality of life because you're spending your whole time on the toilet. So there remains an ongoing clinical need for new therapeutics in this, and I'm not going to spend any time with regard to the detail of this slide, but really it just illustrates that we have a much better understanding of, if you like, the pathophysiology of this condition. And this is just looking at the airways, the airway epithelium, and then beyond that is what's called the interstitium. And as I said, we think the first thing is that there is an injury that occurs to the lining of the lungs, and then beyond that, a dysfunctional repair response, focusing on fibroblasts, as well as a number of other agents. And it's a very active area of research. These are just a number of the drugs that are in development. And indeed, if you go to the clinicaltrials.gov, which, as you know, lists all studies, again, a lot of action in this area that really wasn't around 10 years ago. A number of drugs in phase 1, phase 2, phase 3, as well as phase 4 studies. And again, all looking at slightly, if one of the themes in here is it's in cell signaling, trying to switch off fibroblasts, given that that's the key cell that seems to be driving this condition. And you can see large companies, Roche, as well as smaller biotechs. So, and again,
For using cyclophosphamide?
Pardon?
What's the argument for using?
So there's the trajectory of this condition is that it's a terminal condition. I didn't make that point earlier, that from the point of diagnosis, most people are dead within 3 years, and it's just a steady, unremitting progression. But some patients seem to go into an accelerated phase where they essentially go into free fall, and we call that an acute exacerbation. And there's a feeling that that is an inflammatory aspect to it, and that the treatment rationale there is different in patients in free fall than those who are having this steady deterioration. And indeed, we would use steroids in that space, and people are trying to identify these patients who are having these acute exacerbations and using cyclophosphamide.
When you're using sildenafil, what's the mode of administration?
So that would be oral, yeah, as it's used in pulmonary hypertension. Again, this audience doesn't need to be led through this slide, but of course, when we're talking about drug discovery, we're talking about some in vitro observations, and Mick has talked about how that's been extended to an animal model, and the bleomycin lung model is the standard in lung fibrosis. And eventually you get to planning to do a clinical trial, and the collaboration that we've established, between the Alfred and AdAlta is trying to replicate some of these findings in human IPF tissue. And it's worth saying that not all drug discovery includes that human phase, and some of those that may fail because they don't have that human aspect to the drug discovery pathway. Why are we doing it at the Alfred, or why did AdAlta approach the Alfred? Well, we've established over the last 2 or 3 years a lung tissue bank. As I said, I wear 2 hats. I also operate in the lung transplant service. The Alfred has the country's largest lung transplant program. We do about 90 lung transplants a year, which represents about 55% of the total for the country. And about a quarter of those patients will have lung fibrosis, half of them will have emphysema, cystic fibrosis, pulmonary hypertension. And what happens when a patient with advanced lung disease has a transplant is the lungs are taken out, the pathologists have a quick look at it, and essentially they're thrown into the bin. And we realized a few years ago that that's a huge resource that we could actually be offering up for the development of science. And on the basis of that, we've set up a number of collaborations, both with academic entities as well as commercial organizations. And there's been a lot of interest in being able to access human lung tissue. And the idea being is to create pilot data that aids drug discovery, if you like. Our focus has been in lung fibrosis, interstitial lung disease, and we have ethics. We approach patients on the waiting list, whether or not they'll be happy for us to release their lungs as they come out at the time of transplant to research. But we also realize that you need to have a control group, and we also are able to access so-called normal lungs. They're not totally normal in as much as the owner has died, but you're probably not aware that when an organ donor, the family of someone who's deceased, put up that individual for organ donation, only about half the time do we end up using the lungs. We may not use the lungs because the donor may be a bit older, they may have a bit of a smoking history, and we can approach these families to whether or not they'd be willing to offer up these lungs for research. And they become an important control group that allows us to look at disease pathways in both in the disease itself as well as in the normal lungs. We're in the early stages of this collaboration. We started in the second half of last year, but we've been able to confirm that when we look at CXCR4 in normal lungs, and again, what you're looking for is brown staining. We really don't see any of it in a normal lung, but when we look at a fibrotic lung, all of these brown areas represents CXCR4 that's not there in the normal lung. And is very much around what we call the airway epithelium, the lining of the lungs, not so much in the deep aspects of the lung. And what we're now moving on to is a whole series of functional experiments to, what is the implications of this to other immune cells in the lung, to fibroblasts. So this is my last slide. I think we have a much better understanding of the pathophysiology of this condition, and as a result, there's a lot of academic as well as commercial interest in developing new therapeutics in the interest. There is an unmet clinical need. The treatments, 2014 was a big year, but it wasn't big enough. We do have 2 drugs. They're not yet available in Australia, but there's certainly room for better therapeutics. And I make the point is that we now have focus, and this comes to how you organize clinical trials in what is essentially an orphan lung disease, a rare lung disease. How do you recruit enough patients? One of the things that we've established over the last year is a clinical trials network in lung fibrosis to facilitate multi-center studies in the area. So I thank you for your time. Happy to take any questions.
So in the IPF lung, do you see infiltration of immune cells? Do you see lymphocytes and monocytes?
Yeah, we see a few B cells in there. And again, there's an auto-antibody suggestion. But not.
Are they expressing CXCR4?
We haven't started looking at that. There is some evidence that these so-called fibroblastic foci that our collaborators in the US have done have suggested that they do express CXCR4. And certainly these fibrocytes that are in the blood are like, if you like, a blood equivalent of the fibroblast within the lung.
So the staining you're seeing may be more than just epithelial cells.
Yeah.
Glenn, how do you diagnose IPF, and presumably there's a push to diagnose it earlier?
Yeah, so I think there's an increased recognition of the condition. I think that's possibly just community awareness. But the diagnosis is based on a characteristic history. So you're almost certainly in your 50s, 60s, and 70s. So if you're a 25-year-old, it's highly unlikely. So it's the right patient. And then it's the CT scan. The CT scan is very much characteristic. You have scarring at the bases of the lung. You have scarring at the edges of the lung. And you have these things called honeycombs, which are only really seen in this condition. So if you've got those 3, you've got the condition. And you don't need to do a biopsy. If you've got scarring at the top of the lung, you've got scarring in the middle of the lung, it's highly unlikely to be that. So it's sitting.
It's such a terminal disease, presumably it's easy to treat if you find the patients earlier.
Yeah, absolutely.
Try to do that? There
is this is one of the issues in respiratory medicine is that the lungs have this phenomenal reserve. So you can actually lose an awful lot of lung tissue before you're actually aware of it, unless you're a high-end athlete, if you like, where you can see that your 4-minute mile is becoming a 5-minute mile, a 6-minute mile, a 7-minute mile. But if you're anything like me, I don't do much exercise, so I may be losing lung tissue and not aware of it. So often patients present with quite advanced lung disease when they actually first start to develop their symptoms.
With pirfenidone, in the registration trials, how long were they?
So they were 1 year of treatment.
1 year?
Yeah.
And is that a treatment period could that ever be shortened?
Well, the primary endpoint is forced vital capacity, which is shrinkage of the lung. We think these patients have probably had this condition for 4 or 5 years before they ever are entered into studies. And I don't think you can do, with that endpoint, you can't do 12-week studies. You could probably get away with a 26-week study. You'd probably have to increase the power of the study and recruit more people. So the standard has been 52-week studies.
What's the difference between forced expiratory volume and forced vital capacity?
So they measure slightly different things. The forced vital capacity is the total volume of the lung. So if I ask you to everyone to take a big breath in and breathe out until you pass out, and you can measure that, that's called the forced vital capacity. The forced expiratory volume is how much you can get out quickly in 1 second. Right. So that's a marker that's used in asthma and COPD as a primary endpoint.
There's quite a debate about where the fibroblasts or fibrocytes come from.
Yeah.
Whether they come from the blood. I think we showed some data that suggested the rapid progressors had more of these circulating fibroblasts. Other people say, well, it could come from the epithelium, you show some staining there. Other people are saying they're actually in the interstitium already and they react. So how do your transplanted lungs work out? I mean, if if it's a problem from the blood, then presumably they would still develop
Yeah.
fibrosis, wouldn't they?
Yeah, so this condition doesn't recur following transplantation. Some of the other fibrotic conditions do, sarcoidosis, which we very much think is an immune problem. That does almost invariably reoccur following transplantation. This condition doesn't. And you know, my own take is I think that these are lung resident fibroblasts,
Okay.
the abnormal cell.